So, thank you. So my talk is titled Orbital Mass as the presenting sign of an underlying malignancy, the clinical and pathological features with outcomes. We have no conflict of interests. So what do we already know about orbital metastasis is that they form close to 1 to 13% of all the orbital tumors that are excised. Also, we know that during the natural course of cancer, 2 to 5% of cancer patients may develop orbital metastasis, which is usually by hematogenous spread, with breast, lung, and prostate being the most common primaries. Now, in patients who have a diagnosis or who are diagnosed with orbital metastasis, long-term studies have shown that the mean survival after diagnosis of an orbital lesion is 15.6 months. But the duration from diagnosis of the original cancer to the diagnosis of an orbital mass is somewhere in the range of 52 months, which is almost 5 years. But what about 15% of these cases in whom the orbital mass is the initial presentation of disseminated cancer, where the patient does not know that they already have a lesion or a cancer? So in this subset of patients, where the orbital lesion is the first presenting symptom, what we don't know is how common is it in developing countries, what is the most common presenting symptoms, the most common primary, and outcomes and prognosis, which is why this study was conceived to describe the clinical features and outcomes of patients presenting with orbital metastasis as the first sign of an underlying malignancy. This was a retrospective case review where we had 30 cases of diagnosed orbital metastasis, of which 20 already had a previous diagnosis of a cancer. But in 10 patients, there was no prior history of a cancer, which meant that these cases were the ones where the orbital lesion was the first presenting symptom. The mean follow-up for this entire series was 7.9 months. In the subset of these 10 patients in whom the orbital lesion was the first presenting feature, the lung was the most common primary, followed by breast, prostate, gallbladder, and colon. The male to female ratio was 2:3, and the mean age at presentation was 68 years. The most common presenting symptoms were proptosis, followed by diplopia, swelling, pain, and redness being the next symptoms. The mean duration from the initial orbital symptom to diagnosis was 2.25 months, and every patient underwent a thorough metastatic screen, including a PET CT scan, and the mean number of metastatic sites involved at diagnosis in addition to the primary was 3.3. Surprisingly though, 7 out of 10 patients had no systemic complaint which could have pointed to a primary. 3 other patients had one complaint each of lower back pain, constipation, and severe headache. 8 patients underwent an incisional biopsy of the orbit. 1 patient developed an acute abdomen at the same time and underwent a laparotomy which showed the primary to be a gallbladder tumor. 1 patient who had simultaneous CNS involvement from a primary of a breast underwent a CSF examination which came positive for malignant cells from the breast. All 10 patients received chemotherapy. Our results suggest that the disease had a very aggressive course, with 4 out of 10 patients undergoing radiation and 3 undergoing palliative surgery for treatment of the primary lesion. During the course of the follow-up, 8 out of 10 patients died due to the disease, and in this smaller subset of patients who died due to the primary disease, the duration of between the diagnosis of the orbital lesion and death was only 5.8 months. There are a couple of index cases. This is a 52-year-old female with proptosis of the right eye for 2 months with sudden onset diplopia and pain. Imaging shows a fairly well-defined intraconal with spillover to the extraconal component, a mass with variegated appearance. An incisional biopsy was done which came out to be melanoma. So our working diagnosis was a primary melanoma of the orbit, and during a metastatic workup, it was revealed that she had a tennis ball sized primary melanoma of the rectum which had metastasized to multiple spots all over, including the orbit. This was a case of a 67-year-old male who had sudden onset pain, proptosis, and diplopia, was being treated elsewhere as myocystic uh, MRI showed a well-defined mass with an infarct necrotic central lesion. An incisional biopsy showed a primary adenocarcinoma of a lung. Again, metastasis showed liver metastasis. PET CT showed metastasis in the liver and multiple lymph nodes being affected. This was a patient who had come from Africa and was referred as a lacrimal gland tumor with a 3-month history of pain, double vision, and proptosis. There was bony lysis with an infiltration type of lesion. An excisional biopsy was attempted, but it could only debulk, and it was the histopathology suggested to be a breast carcinoma. As you can see, the liver, the lung, and the breast all showing hotspots on PET CT. So the mean survival in literature, if you look at data from the West, the mean survival of cancer patients who've been diagnosed with orbital metastasis is 31 months. But our cohort of patients in whom the orbit was the first lesion, the mean survival is only 5.8 months. This is another series where they had 1/3 of the patients with no known primary. But most of the papers suggest that there is no significant difference in survival in patients in whom a known primary is known versus an unknown primary at the time of diagnosis of an orbital lesion. This was again the similar findings from another paper from UK. However, in our study, patients with a known diagnosis of cancer and an orbital metastasis, the survival period was 12.3 months, and in those without a known primary, the survival was 5.8 months, which is less than half and obviously significantly different. On radiological features, there was nothing particularly a characteristic of these lesions, although diffuse infiltration into the muscles was seen in 7 out of 10 patients, and most lesions were unencapsulated. So is there a case for us to treat all patients or adults with orbital lesions as orbital metastasis unless otherwise proved, as long as they have the following red flags, which is a recent onset of abaxial proptosis with diplopia, pain, and no evidence of inflammation? So to summarize, in India, systemic malignancies presenting as orbital masses is possibly more common than expected. These patients have poor prognosis with significant shorter survival, and as they present later on during the course of the disease, more metastatic sites are involved. PET CT, of course, is crucial to stage the disease. In patients who present with the red flags of sudden onset diplopia with pain without inflammation, we should have a low threshold for biopsy, which is based on imaging. And palliative treatment may be considered as an option given that we know the outcomes in these patients is very, very poor.